Good morning alle sammen. Good morning and welcome to this first session of today. It's a Medtronic-sponsored session, and it is about sacral neuromodulation as a treatment for fecal and urinary incontinence after birth. So complications there. We are happy to introduce Michael Sørensen, who is a colorectal surgeon, is one of the pioneers in the field of sacral neuromodulation. He has been implanting and helping patients more than 25 years, and he is one of the leading in this field in Europe, and I can also say actually in the world. It's because of Michael, some of the very big ones in US actually know how to perform this therapy. So Michael, welcome to this morning, and the stage is yours. And by the way, before you start, if you're out there watching this session, please, if you have questions, just type it on the computer or the pad or whatever. So we will take the questions in the end. So the floor is yours, Michael.
Thank you. Thank you, Henning, and thank you for this invitation. And I have only one disclosure. I have been hired by Medtronic in a couple of times. Okay, what is sacral nerve modulation? It's a way of sending electrical signals to the sacral nerves by an implanted electrode and a battery or a stimulator placed in the buttock, as you can see. What we aim to do is to place the electrode very near the nerve, and I'll show you later how we actually try to do that. We start with placing a needle through the sacral bone, and we can stimulate this electrode, this needle, and we can see that we are in the right place, right next to the nerves. And in this, you can see we place the nerve, the needle, and hopefully it should start. Yes, and we stimulate, and we can see that we are in the right spot when we have the contraction of the sphincter muscles. This is what we like to see. That's the S3 response we have there. And we always prefer to have it placed in the S3 because it's when we place the permanent electrode, it's more stable when it's in the third foramen. After we've found the right space, we want to place the permanent electrode. And first we put in a guide wire through the needle. And we look at X-ray to see that we are in the right spot and how deep we want to place. Small incision, and we put in the lead introducer, it's called. It's a white sheet. And again, we check with X-ray that we are in the right place. This is the electrode we place. It has 4 stimulating points and also something called tines that anchors the electrode for long. And now I've placed the electrode, and we check if it's still in the right spot. And when we are satisfied, we remove the lead introducer. And the electrode is now in place. This is a minimal invasive procedure. The oldest person we've operated so far is a 96-year-old lady, so everybody can benefit from this operation. And we can usually, the operating time is about 20 to 30 minutes, depending on how much experience you have. So it's a good Now we go to the next. These are the motor responses that we go for. We call it the bellows of the perineum. That's what we saw before. And also when we see a flexion of the great toe, we're very happy because then we know we are in the S3. After we place the electrode, we extend the wire outside of the skin and use the test stimulator instead. And they usually, when it's fecal incontinence, they will usually test for 2 weeks. Urinary incontinence is 1 to 2 weeks they test. So more specific about the indications. Well, first of all, urinary incontinence is quite common after childbirth. I'm a colorectal surgeon, so this is only what the little that I know about this, but up to 45% have urinary incontinence, and it can be all types of urinary incontinence. The risk factors are parity and high body mass index, older women or older ladies when they have babies, and if they have urinary incontinence before they were pregnant. Also vaginal deliveries, and if you have to do some kind of operative procedure during the childbirth as well. And of course, high birth weight of the baby. And all these risk factors are just the same for fecal incontinence. And it's a predictor for having a sphincter lesion as well. If we look at the EAU guidelines for urinary incontinence, there's a strong recommendation for botulinum toxin and or sacral neuromodulation in patients with mixed incontinence and urgency. If you go to the ICI recommendations, it's the same strong recommendation of both botulinum toxin and sacral neuromodulation. Whereas botulinum toxin can probably be done in a lot of places, you need more specialized centers in order to do sacral neuromodulation. So if we look to surgical management of fecal incontinence, you can always discuss if they have a big sphincter lesion, you would very often do a sphincter repair first. But if it's an older lady, a sphincter repair can be quite bothersome, and in most patients it's actually possible just to do a sacral neuromodulation and still have a full effect on the continence symptoms. So that's at least what we do in a lot of times. But of course, if you have a sphincter lesion, it's in younger patients, I would prefer to do a sphincterplasty. But already back in 2008, we found out when we started first with sacral neuromodulation, we thought we had to have an intact sphincter. If you saw the motor response, we saw a sphincter reaction, and we thought you had to have an intact sphincter. But already Chandra and co-workers in 2008 found out that you don't need to have an intact sphincter because continence is so much more than just having a sphincter. It's also about how regular your bowel movements are. The consistency of the bowel content is also important. So a lot of patients will actually be full continent even if they have a big sphincter lesion. In our old material from Hvidovre Hospital where I work, this is actually 9 years old, but it's just to show how the different people we actually operate. Most of the patients we see are women, which is somehow odd because when we look at the incidence of fecal incontinence, if you're plus 60 years old, it's just as common in men, but they don't see a doctor. But in our material, a lot of the patients had a sphincter rupture. Some of them had a sphincter repair, but not all of them. So, but most of the patients we see actually have idiopathic fecal incontinence, where we don't have a cause that we can find. So, but since it's such a small procedure, we almost test everybody. They always go to a conservative treatment first, but if the conservative treatment fails, we will do sacral nerve modulation, and we test almost everybody because it's such a small procedure to do this, and everybody can tolerate it since it's minimal invasive. So, so that's why it's such a broad spectrum of patients. But we do have great success with idiopathic and sphincter rupture. We have, as I will show later, more than 90% success. But of this sort of mixed group, we were happy to see that close to 80% of these patients would actually benefit from having a sphincter, an implant. And if we look on the long run, more than 80% of these patients will have it after 10 years, will still have an implant. So it's quite a good operation. 6 years ago, I met with one of my good colleagues, who is Klaus Matze, who is actually one of the first persons who performed this procedure. And we talked about operating together just to sort of learn something from each other. And Klaus Matze came up with the idea that we should collect a whole group of surgeons and talk to Medtronic, and they agreed on this and sponsored this. And they also wanted urologists to participate. And we have this expert group that met first time in Copenhagen in November 2016. And we performed 3 operations together. And that's probably one of the most dynamic processes I've ever attended, because this first paper was almost done already after that first day, because after a 2-hour discussion, we said this is so important that we have to come forward with this. And we came forward with this standardized electrode placement technique, and I think it's one of the most cited papers when you look into sacral nerve modulation. We continued in this expert group, and we came up with some basic programming so that all centers should actually be able to perform these very simple things without having much help from Medtronic, which has been a big problem so far, because a lot of centers do a very few operations, and you need to do a certain amount in order to be able to both do a safe operation with good results and be able to program the patients. So we came up with these 2 papers, and there are more papers from that groups, besides with more advanced programming as well, and a paper about how does it actually work, all this. So you can look it up if you want to. Yes, I said I would talk about our success with the, after we have standardized the procedure. We made a multi-center study together with Tromsø and Aarhus, and since we've had this great success, we want to sort of see how good are we. And all these 3 centers do more than 40 implants per year, so it's a high volume centers if you look at it worldwide. And what we did was we actually did a 1-stage procedure. Instead of testing for 2 weeks, we placed the stimulator in right away. And as I said, it's a minimal invasive procedure, takes 20 to 30 minutes. And the inclusion criteria for these patients were that they had to have idiopathic fecal incontinence, or if they could have a sphincter defect, but no more than 130 degrees. And we randomized them to 2 groups because we also wanted to check if there was a dose response curve. So some of them were randomized to not having any, they were not stimulated for a month. So, and the results of this were that 92% of patients had a more than 50% reduction in fecal incontinence episodes. So it's very effectful. But since we have been so good at placing the electrode, 11% of the patients actually had an effect with only having about 0.05 milliamps, which is the lowest we can stimulate with. So this new standardized technique is really good at getting close to the nerve so that we can make, because the less current you need to stimulate, the longer the battery lasts. This battery is designed to last for 5 years. We now know that it will probably last for more than 10 years because we have changed this whole method. And that's since the battery is the most costful part of the treatment, it's a great achievement that we can prolong that to probably double time. So yes, and so in conclusion, we know that sacral neuromodulation is well documented as a treatment for both fecal and urinary incontinence. And if you are in a high volume center, you have more than 90% success rate, which is, I must say, pretty good. So I usually say that out of the whole pool of patients that we have admitted for fecal incontinence, less than 2% cannot be helped. So it's a shame that we only see maybe 2 or 3% of all the people that actually have fecal incontinence. So yes. So if you have any questions, please forward them.
Yes, thank you, Michael. Thank you, Michael, for a well-done speech this morning.